surgeon in the Division of Pediatric Neurosurgery. Since his arrival here, he has really developed our reputation and resources as a major regional center for children and infants with complicated brain tumors and other similar lesions. Dr. Ruge has been the director of the Midwest Children's Brain Tumor Center, which attracts some of the most complicated patients from a variety of states around the Midwest. He often will tackle the children whose own physicians, whose own neurosurgeons are reluctant to go after some of these very difficult and hardly accessible lesions. Dr. Ruge has expertise in a broad spectrum of disorders in pediatric neurosurgery. This morning he will be addressing one of the very challenging ones, and that's the infants and children with Chiari malformation. Dr. Ruge has indicated to me that he has no disclosures to make, and on behalf of the Department of Pediatrics, there's no external financial support for this morning's educational activity. Please join me in welcoming Dr. John Ruge.
It's a pleasure to talk to you about this subject that is fascinating to me over the last 25 years of taking care of these kids, with Chiari malformation. There's a lot of fact and fiction, and I'm excited today for a couple of reasons. One is to hopefully give you some useful information and clarify a few things, but also today we're honored to have this very special group here, the Chiari and Syringomyelia Foundation, that will speak at the end of the talk, and I'll show you what exciting things they're doing, and I'm really pleased that they're here today. So this paper in the late 1800s was the introduction of Chiari. This is Chiari's original paper describing his malformation. He was a pathologist in Vienna and did autopsies, and on the autopsies he saw a bunch of people, children particularly, who had hindbrain problems. That the back of their head had issues. And he described this and published this and put together categories, 1 through 4, Chiari 1, Chiari 2, Chiari 3, Chiari 4. And then this has been endured over the years, and we're going to talk about some of these. I'm going to focus on Chiari 1 and 2 because there's these are the ones you're mostly going to see. Chiari 3 is a picture here, and that's not hard to diagnose, occipital encephalocele. And Chiari 4 is a cerebellar hypoplasia. Recently, there's a couple other categories that are being put forward, and that university accepted them, Chiari 0, Chiari 5, and Chiari 1.5. And we're not going to go into the nuances of that for your sake. These are the ones that we need to focus on. Chiari 2 is a true malformation. And I'm going to make a case that Chiari 1 is not a malformation. It's a herniation of normal contents. Chiari 2 is a malformation in the true sense, and it only occurs in children with mild meningocytoma. So that helps sort it out for you, the diagnosis. And this is what it is when the spinal cord is formed, the brain and nervous system forming, that there's a relative tethering of the lower elements of the nervous system, and it pulls the development into this canal so that the medulla, which is normally up here, is pulled into the canal. There's a medullary kink. Fourth ventricle, everything is distorted here. And where the tentorium lies, even the skull around it. And if you cross-section through this area, look under the microscope, it's also wrong. The cerebellar, the nuclei, the brainstem nuclei are not in the right place. And these children have lots of problems. This is the most, some of the findings on MRI scan are, you see the characteristic cerebellum coming out, but also medullary kinking and this distortion of the clivus and the brainstem. Here again is another picture of the beaking. There's multiple features that we can discuss. The low set tentorium, the medulla peaking here, the L-shaped posterior fossa. And this is often associated with the syrinx. The syrinx is hydromyelia, syringomyelia, is fluid accumulation within the spinal cord. It's not supposed to be there. There are a variety of different reasons to get that. I'm not going to focus on syringomyelia today, except for its relationship with Chiari. It's a bad thing to have for these kids. It accounts for most deaths in children with mild meningocoel. And recently, we just had people in NICU know a beautiful little girl that died about 3 weeks ago at home from Chiari issues. So we see this, and this is a real factor. Even though I decompressed her, the structure of the brain is not right. And kids have swallowing difficulties, apnea, motor weakness, stridor, and numerous other dysfunctions like this vocal cord paralysis picture. But now I want to focus on Chiari 1, which is much more common. And Chiari 1 is called the Chiari 1 malformation, but really it's a herniation of the cerebellum into the spinal canal through the foramen magnum. And this is how we diagnose it. A line is drawn by the radiologist, and Barkovic and his colleagues looked at different ones and saw that if you say 5 millimeters down below the foramen magnum, we're going to call that abnormal. And right there you can see where the problems arise. You draw a line at 5 millimeters, does that mean that a 4 millimeter is normal? So we run into problems. And it has to do not only with the extent of the descent of the tonsils, but also the spinal fluid space around here, the cisterna magnum. It's a very important feature. Although many kids, I think, are not diagnosed because they come close, but they don't meet that criteria. And so they're dismissed as not having Chiari, when in fact they may be very symptomatic. We know if you flex or extend your head that the cerebellar tonsils can also change in this descent. So right off the bat, you can see where we're going to get into some issues. And the one issue that I take extreme point with is this idea of a malformation, because patients who come in and think they have a malformation think they can't be cured, and they can be cured. It's a herniation, and I like to use Hal Ricate's analogy of an umbilical hernia. If you got an umbilical hernia, it hurts when you cough or sneeze, and what comes through there may be bowel, and the bowel may be injured. In this situation, it hurts when you cough or sneeze because of the herniation through this area. But what's coming through there is the brain. And so you can imagine, it's a very important part of the brain there, the brain stem, cerebellum, and all the different symptoms that come out of this are related to that part being squeezed or pushed or affected. And it makes sense. You know what happens down there. You know the symptoms that can come. It's not depression. It's not swollen lymph nodes. And I'm going to show you some things that are fiction out there today and are being touted as fact. But here's the normal, and it's very important to CSF space. When we cough or sneeze, something has to just be displaced out of this container. And so spinal fluid normally is displaced. And when you lose that cushion, then you just start to displace brain. And then you run into lots of problems, including a syrinx can develop. It's pretty common. This series from Kaiser Permanente recently showed that in their MRI interpretations, 0.5 to 1% of the children they looked at had it. Most kids are often asymptomatic from this, and the general number is 1 in 1,000, but anywhere from 1 in 100 to 1 in 1,000 people have it. So these kids come to me in 4 ways. Okay, they come because it's an incidental finding on their MRI. They're asymptomatic. They just come in the door. They have the classic symptoms, which I'll go over with you. They have multiple symptoms like this. They bring in a laundry list of symptoms. Some of them may be related. Or they come in because syrinx has been discovered and led them to figure out that they have a Chiari too. So what are the classic symptoms? 85% of these kids have a tussive or strain-related headache at the occipital region, right back here, or the neck pain. You cough, sneeze, it's like an umbilical hernia. It hurts when that goes through there. And it's always midline. It's never a right periorbital headache. It's always in this area. It's a very important feature. And these are symptoms that are known. And there are a lot of symptoms because it's an important area of the brain. A lot of information goes through there. So some of these are understandable. Cerebellum compressed, numbness or tingling in the hands or feet, often because of the syrinx. Dizziness because of the vestibular center, difficulty swallowing, slurred speech, vision problems, is sometimes because of hydrocephalus associated. Ringing and tinnitus because of the 7th, 8th nerve complex, syrinx issues, chest pain, syrinx issues, scoliosis off the syrinx, and this because of the sleep and respiratory centers located in the brainstem. The treatment, what's the treatment? There is a cure if you catch this early, and that is before there's, if you constantly bash your brain into this bony opening, you're going to cause some permanent problems that surgery won't cure. But it's not like a Chiari 2, where you cut through the brainstem and everything's all awry. These are normal brains. And it's also the only Chiari that can be acquired, and we're going to talk about that. But surgical experience shows that surgery works. 85% of the time that whatever's wrong often gets better with surgery. And analysis of, these are recent studies showing, do the patients feel better? Yes, about the same period of time, 85% of the time. And I think we can do better than that with better selection of patients. And I'm going to show you some. This is the surgery. This is my friend Fred Geisler.
Here is a patient with the inferior part.
But I think he did a good job in showing what you do.
And the skull to the left. The drill right here is cutting the arch of C1. Now the arch of C1 has been removed. This exposes the underlying dense fascial tissue overlying the dura and spinal cord. A hole had been drilled in the skull, creating a larger decompression area. Here are some of the membranes in back of the dura being resected with a sharp blade and taken off. The white material being placed down is a hemostatic material to get hemostasis. Here the dura is being opened with a sharp blade, exposing the underlying spinal cord and brainstem along with the descended cerebellar tonsils. Here the arachnoid adhesions are being taken off and cleared up, and then a patch derived from pericranium or tissue at the edge of the wound is brought into the wound and sutured into place to form a watertight closure. After completion of the patch, more hemostatic material is laid down to stop any residual bleeding. It is then irrigated out, and a special bonding gel, which is blue, is then placed down over the top of the repair, the retractor.
So that's what's called a duroplasty. The second part where they open the dura and put a piece of something in there. And there's been an evolution in the last 25 years, and I've gotten away from doing duroplasties, and I only use them as for failed craniectomies. I do a dural scoring procedure, a modification of this. Here's one of the things with children. Children are changing. So when a child comes in to me at 4 or 5 years old with a Chiari malformation, I don't know what that child's going to be like when they're 18. We do know that, contrary to what you think, that everything sags with age. As you age, the cerebellum actually rises. The cerebellar tonsil, there are norms per age, and up to 6 millimeters in a 5-year-old, and is probably within normal, and but only up to 3 millimeters in an 80-year-old, because the atrophy of the brain actually pulls the brain up. The other thing is, so leave asymptomatic children alone, I tell my colleagues, okay? Dramatic MRI findings in a 2-year-old may not be so dramatic when that child turns 20. And I've seen spontaneous reductions in resolutions of syrinxes and symptoms with aging. So I'm very conservative on these children. And in fact, the literature shows that there is a group, what happens to some of these kids that don't have surgery? Well, at 2.5 year follow-up, these kids did not develop any new neurologic symptoms over this period of follow-up. So it's not like this is a cancer that needs to be taken care of. And my mentor, Dr. Ramundi, led me into pediatric neurosurgery, bless his soul, said this, be a better doctor than surgeon. And the mission of the surgeon is to operate only when necessary, whenever necessary, but only when necessary. And I carried his views with me. I'm going to show several quick cases. I'll be done in 10 minutes, and I'd like to then introduce some dynamic women to talk about some more details of this society. But this is a lady who's had headaches all her life. It's an unusual story. Strain-related headaches. I thought it was normal until she got in an accident down in Florida. When she got in an accident down in Florida, became transient quadriplegic. Could not move her arms, legs, or nothing. They did a scan down in Florida, said she's got a spinal cord tumor. My buddy in Chicago calls me and goes, my sister's got a spinal cord tumor down in Florida, can you do something? So we brought her up here, and this is her MRI. It's not a spinal cord tumor. This is a syrinx with a Chiari. This is the first bone in her neck. This is the back of her skull. This has come down. And she's been living all her life with this syrinx and was traumatized. So I took her to surgery, early post-operatively. You can see the post-op changes. Still the syrinx is big. 1 year post-op, and I put her back pre-op, post-op. You can see the spinal fluid now that flows back behind here. The syrinx is much better. She has lost her lifelong headaches are gone. Why wasn't she treated 20 years ago? Because people aren't aware of this condition. And what's going on. There's a reason. This is a beautiful case. Many people in this audience probably know this girl. A 15-year-old girl comes to my office with a laundry list of complaints. Oh my God. It's one of these patients that come in your office and you say, okay, I've got 45 minutes left. This is going to take 2 hours. I mean, and she has every symptom you can think of. And you're thinking, all right, you got to weather this. I don't know what system you even grab onto here. But she was a straight A student formerly, played high school athletics, and started having headaches in January. Fell playing basketball, and all these symptoms progressed. She saw 7 different doctors, had 2 spinal taps, was diagnosed with pseudotumor cerebri, which can be associated with it, but was treated for pseudotumor. Didn't get work. She dropped out of school, basically, gained 35 pounds, was laying in bed, and developed every symptom known to man. And this was her MRI scan. You can see the cerebellum hung down here. She had a Chiari malformation. So I took her to surgery, did a bony decompression. Here's pre-op, here's post-op. We've got nice spinal fluid. I saw her in the office last week. She's lost 35 pounds. She wants me to release her. She's going back to school. She wants to try for the golf team. She wants to try for the other team. She's back on top. All her symptoms essentially. I mean, I would love to put this out on your website. So, I mean, this is amazing. This is a typical kind of, not as typical one type of case that comes in. This is another child, took care of a 13-year-old female cheerleader athlete. She's been living with headaches in the back of her head, missed school because of the headaches, was on all sorts of headache medication. And had this MRI, which shows the cerebellum tonsils extended down below the arch of C1. She did not have a syrinx, and I should mention, I'll mention this again, when you discover somebody has a Chiari, always check the spine. You always need a full spinal screening MRI. 20 to 70% of these kids will have a syrinx. You got to know about it. She didn't. So in January 2009, it decompressed her, and 7 months later, she's doing great, rare headaches. I was patting myself on the back, everyone was, and then her headaches came back in July 2010. She came back to my office on medication, we decompressed her. Oh, so maybe this wasn't the cause of her headaches, what's going on? I get a scan, and now she's got a syrinx. She never had this syrinx before, okay? And so I'm pretty conservative. I said, well, I'm not sure, let's wait. We waited several months, repeated it, now the syrinx is getting bigger. And it looks like there's some spinal fluid, but probably not enough. So I took her back to surgery in February of this year, did a duroplasty, opened it up, expanded craniectomy, and now she's fine. Her headaches are gone. She's back to driving. She's a happy girl looking forward to school. This is her recent MRI showing a lot more room back here and a smaller syrinx, and we'll watch that hopefully go on and shrink. The last case, I just saw this child recently. This is a 5-year-old who comes in the office at age 2, bumped his head in an apneic spell. And we don't know if this is a breath holding, which is fairly common. And that's what it probably was. Until 6 months prior, he stood up underneath the table and became apneic, hit his head, became apneic. His father's an EMT. He did CPR on him, resuscitated him. I don't know if it was a breath holding spell you've got a father who's an EMT, just, jumps on him, or if this was really a significant happening spell in that sense. But anyway, he comes in my office, playful, asymptomatic, no headaches, running around the exam room, nothing's wrong except for these 2 spells. And this is his MRI. See the cerebellum down, he's got a syrinx, and in his lower canal, he also has a syrinx. I'm not sure at this point I'm watching him. He's a happy kid, has no problems. And I'm hopeful that at the time that he might outgrow this, other of my colleagues would operate at this point. At this point, we're watching him very closely. He may or may not require surgery for this. So, in summary, I'd like you to consider Chiari malformation when there are strain-related occipital headaches or tussive headaches, post-traumatic headaches that don't go away after the trauma, that are typically occipital. A syrinx is discovered, or you find cerebellar brainstem findings in people on exam, like otherwise unexplained choking, apnea, and swallowing difficulties. And also, the patient has an overwhelming variety of symptoms that you just cannot put your hand on. And it seems to be a reliable patient. Consider this. And when you consider Chiari, consider Syringomyelia. Always look for a patient who's diagnosed with Chiari. There are a lot of lies out there, and a lot of people telling that intentionally, but they just don't know. And so it's very important to have facts. This experience is growing, and thank God for the CSF Foundation, which is a wonderful place to go to get facts. And they encourage well-grounded research in this very common problem. And with that, I want to introduce the CSF Foundation leaders, the founders today, which is extremely fortunate. This is their website. It's extremely the opposite of the video I showed you. It's got patient information, physician information. It shows, as we drop down, research that's going on, videos that are useful, and lecture videos that doctors can use. It's just an amazing website. One of the founders is here, Lori Watson. Both Lori and Dorothy, well introduced, have been personally touched by this in their family in some way, and taken that energy to do something extremely valuable for other children and families. Lori Watson is the director and one of the founding members of the society. Dorothy Path is a dynamo as well. Graduated Juilliard School, lives in New York, flew out here to be with us as the executive director of this, as they're trying to establish, as they are establishing a Chicago chapter, which I'll talk to you about. With that, I'd like to introduce both Lori and Dorothy, who have a few words to say.
Hi, I'm Lori. Dorothy. And I'm Dorothy. And Dorothy's going to take you through a really brief presentation because we know how busy you are. I just want to start to lay down a premise. You guys are part of a pilot program that we're starting today, thanks to Dr. Ruge. One of the things for me personally, because it took 2 years to diagnose my classic symptom son 14 years ago, and Dr. Ruge operated on him, for me is getting a diagnosis earlier in the process. One of the things you said is if we catch it early, we really can cure this. And the catch it early part is the part that, my part of the foundation. To do that, we have tried to figure out who our target audience is for that. And you guys are the first target audience. We really believe that this part of the campaign in educating physicians who may not have considered Chiari as a possible diagnosis can start to consider Chiari, and we might be able to really put Chiari malformation on the radar. So if you can kind of think about that as you're watching this, and thank you for filling out the surveys. If you haven't already done that, we can collect them at the end, and we will get back to you and get your feedback on this presentation after a month or two maybe.
Hi, and I'm Dorothy Path, and I want to thank, first of all, Lutheran General and Dr. General Ruge for having us here today. It truly means a lot to our foundation. And our foundation is a little new, although I've been involved since 1991, so I go back a long way. And my son was 4 at the time when I got involved. I'm sure he had Chiari and Syringomyelia from birth, but just wasn't diagnosed for 4 years. And I came from like what I call the dark ages, because back in 1991, if you found a paragraph about this in a book, there was no real internet. Like we had Prodigy, and I'm sure I'm older than all of you, and it was supposed to load, and you'd wait for each word to come out, but there was nothing health-oriented that you could find for something for your child. And at that point, Chiari malformation was considered a rare disorder, which meant that less than 25,000 Americans had it. So there really wasn't a lot of information. There were not groups. And I was very lucky that I did find 22 children across the United States that had it. And I have a box of their medical records in my attic, which is how I started. So I have and I said, there has to be something here. I don't know what it is. There's some common thread. And my thought was, well, I'm not smart enough to figure this out, so let's get groups together, groups of medical professionals who might have an interest in it. And luckily, there were people out there, Tom Millerat, who was like one of the fathers of getting all this going, and Rick Batsdorf out of UCLA. Those were the first 2 physicians that I met, and they kind of took this on and helped form a foundation and get it to grow. So, we're now at 2007, and we have CSF. And this group is an exceptional group because the board of directors that we have and the founding members are really smart, savvy business people, as well as being personally affected. So that makes this organization forward-thinking. It makes every decision that we make a passionate decision because it will affect their children or their loved ones. So it's a good core group to start working with. And having the foresight to put this all together, one of the things that our organization does that a lot of organizations don't do is we're seeking 3 approvals. And if you have other charities that you're working with for other disorders, I recommend that you use these as kind of standards. And one is GuideStar seal of approval. And they go through and they check, are you doing things right? Are you filing with the IRS? How's your information being collected? And they kind of rate your charity. We've gotten their approval. Second thing is the Better Business Bureau. What are you doing with the money? You know, do you have the people who are just collecting it and saying, well, we'll spend it however? Better Business Bureau has a set of 22 guidelines. We are probably 3 weeks away from receiving this seal of approval right now. And it's a long process to go through, but it's definitely worth it. Again, have your other groups check out if they met those requirements. And I think this is the big one. We are in the process of redoing our website. Now, our website was done by all medical professionals. It's not lay people writing articles on Chiari or Syringomyelia or making things up. It's peer reviewed. We have, which I'll get into, we have a great medical resource team. But the Health on the Net code, you have to go back and you have to cite where you got all your information and who published it and when it was published and when you put it on the net. So it really makes a charity accountable for the information that they're putting on the net. And I think that's key. And our organization is 100% behind having accurate information to disseminate to lay people and or physicians. Now, this is our board of directors. We have a staff of 2.5, and we are all over the country. So we wear many hats, and our board is a very vibrant board, good group. The second thing we have is a board of trustees that's international. And if you look, the top 3 are from the 3 big medical device companies. They've actually taken out their scientific directors and whatever to join our group because they feel what we're doing is valuable. So I think that speaks volumes. The other thing is we're going international in scope. We have a huge group in England right now, and we're starting to fund international research as well as research within the United States. So that's a good group. And I think this is the crown jewel because these are the people that drive our organization, which is usually the other way around, where the lay people are pushing them. These doctors from our Scientific Education and Awareness Board actually take on the projects of writing the material, reviewing the grants, putting out the RFPs for us. They attend research conferences. I have Howard Cave is actually setting up one of our seminars in New York. So they're actively involved. It's a big group, and I'm sure you recognize a lot of the names because they're world class. The other interesting thing is we have engineers and we have a veterinarian because Chiari malformation is also very prevalent in the King Charles Cavalier Spaniel as a model. I have a dog who had Chiari surgery. I also have a dog and a son. And they're both doing well. My dog had the more advanced surgery because he got the titanium mesh and the whole thing. But and he's doing really well. And he's on gabapentin. He's doing real well. So it's an interesting group of people, and their collaboration is important. And then we never lose anyone off the board. We just move them to the senior advisory panel, and they still participate. So we have a three-pronged mission. One, educate, awareness, and research. So how do we educate? We started out by setting up 9 chapters in the last 2 years around the country at major medical institutions, so we get good groups together and doctors who are willing to work with us. That said, what we do is we're taping today, so this will go on the net. And the goal is to have information available to people whenever they need it free of charge. Last year we had 78,000 people view our educational videos. So even though there are only, 45 of you here in the room today, you're talking about 78,000 people who have access to material. So we're getting the message out there, and I think that's huge. And now I'm going to turn it over to Lori, because Lori is working on our Chicago chapter.
Great. Our plan is to go into teaching hospitals or hospitals where we can gather like this and have a well-respected physician kind of host for us and bring in people. This is the first, we have chapters established, but this is the first time we're doing it with this kind of a start. And what Dr. Ruge has agreed to host, I just put this in here, hopefully that's okay, to host the next lecture where we will invite patients as well. Once we get the patient population involved, then it kind of feeds on itself and we have a self-sustaining chapter. Where you guys can come in and where you can really help us is helping create awareness. So we want to be the place that people go instead of YouTube. And I don't know if you got some coffee, just carrying around your coffee cup. If you can take, we are launching a campaign called the Consider Chiari campaign. Right now, we're just targeting physicians, so we're going to be in places like, the WebMD websites and things like that electronically, but we're also going to be in airline magazines and Golf Digest and things like that, so we can reach doctors when they're not necessarily thinking about their patients, but kind of pull them back in when they're kind of in a relaxed mode. So any way that you all, and this is why she went through all the ways that we're certified, we want you to have a level of comfort with us. Hopefully Dr. Ruge has given you a level of comfort with us, that if you come across this, you can say, here's what I know, but let's both together go to the CSF website and we can learn a lot more. So we want to be that place for everybody. So we'll let you all know when Dr. Ruge is going to be having his presentation, and hopefully you can mention to some of your patients or some people you're seeing in the hospitals or seeing bedside, hey, this might be a place where you want to show up and get some information. This is the ad that's going to go to lay people. It's not much different. You would see this in something, if we did a layperson campaign, you'd see it in Reader's Digest or People Magazine or something like that. We don't have the funding for that yet. But the physician ad, which please take a poster and please hang it somewhere where there's a lot of traffic, is on the table. And like I said, you'll see that in Health Digest. You'll see it hopefully blanketing your hospital after we get through the red tape of being able to hang a poster. The other thing is we'll unveil our campaign at events. Bobby Jones, the late great golfer, had Chiari and Syringomyelia. I don't know if you know that, but his family is it his grandson? Is intimately involved in all of this. He's on our board. We do a golf tournament, we do a walk, a United Night Walk, we do a charity balls across the country. We do a huge thing in Washington, D.C. And locally, this is in Barrington, and you'll all get an invite. We do a wine tasting. And it's just a way to generate awareness and also kind of give thanks to the doctors and the medical professionals who are kind of, spreading the word for us. It's sort of a thank you to you guys as well. Night of Light Gala in Washington, D.C., and that's where we're going to be unveiling this campaign, and hopefully that you'll start to recognize it and see it. And you will have been the first people to hear about it. So, do you want to say anything else about research?
Yeah, just briefly, I think the interesting thing, these are the things that we've done in 2 years. So we've been up and running, we got our incorporation in 2007 November, and 2007, we've done quite a bit in 2 years, to get chapters up, to get all this up, but it's because we have the medical professional help. And the other thing is, we don't think of ourselves as competing against other organizations. There are other Chiari groups out there. We're not here to compete. We're here to find answers, and we've actually helped fund different symposiums that they've run. So I think that being open-minded, inclusive, we're going to move ahead. And I thank you very, very much. Visit csminfo.org.
Thank you. Please take a copy out of the poster and a paper pen for
I heard someone, and I cannot remember who it was, speak about this when I was in my training institution, and maybe that person was more gung-ho surgery, but one of the things they talked about, or this person spoke about, was some speech delays and speech problems in children, and if you wait too long to do a surgery, that can be irreversible. So I was just thinking about this 5-year-old that you're watching. If that child were showing problems with learning or kindergarten or reading or other thing, or sort of expressive speech, would that change your opinion on if they were symptomatic?
Yes, I think, that's the key sometimes to figure out how symptomatic. There's a whole group of population we term mildly symptomatic, and those are problematic because I have a lot of patients I haven't operated on who have some occipital headaches. They take a couple Tylenol, an ice pack. Do you want to live with this? They're okay with that. They're called the mildly symptomatic. And what organizations like CSF are hoping to see more about the natural history. And we have a huge problem in this field about understanding natural history of the patients. If you have it at this level, this type, what happens to you 10 years? What can you expect? And here, part of the problem is that with the child, the relationships are changing. Karen Marasco in Michigan has put out a lot of neat information about documenting the changes with age in the structural growth of there's a relative growth between the skull and the brain, and who's going to win? It's a container problem. So I think yes, if that patient I just showed does have things that I think you'd be suffering from, speech or other issues, then yeah, I decompress them now. And I decompressed an 18-month-old, okay, who was suffering from it. The kid, his mom brought in a video. I think this is one of the youngest kids ever decompressed, at least back then it was, 20 years ago. This mother brought in a video, the kid eating in a high chair, eating, and would scream and then grab, like it would wince in pain, grab up towards her head. And the child had a Chiari malformation with Valsalva, and we decompressed. At that time, it was Dr. McClone and I down at Children's, and Mom wanted both of us, and the child did fine. So it's very difficult. It's not an easy condition to, and if you see 10 neurosurgeons that have 10 different approaches.
When the moms come in with the video and all that, like those are really, you know, there's a problem there. I do think that some of it speaks for itself. I mean, you get a parent in there who's been exasperated and they've got a spreadsheet of where they've gone and what they've done and whatever. Those are easier to make a call. I mean, you met us and you said, let's do it Monday. My God, I don't want this kid to have one more day like this. I mean, it was an easier call. But it's the ones that are in the middle that are kind of gray that it's tough, especially with kids because they can't talk. They're just grabbing at their head.
Are you still seeing delays in diagnosis?
Yes.
Oh my
And
gosh.
where is the origin of it? Is it at the primary physician level or
and
second?
I predict it's going to be more of a problem. If you go to our meetings, there are incentives now for primary care doctors not to order MRI scans. And this is very hard to diagnose on CAT scan. And so, and headaches are a very common problem. So I predict that this is going to become even more of a delayed fashion as primary doctors are reluctant to order MRI scans on children with headaches.
On our ad, it's a checklist, if you have to actually read it, is your patient presenting with a collection of seemingly unrelated symptoms? Have countless tests failed to suggest a single diagnostic possibility? Has your patient been diagnosed with migraine, blah, 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 and MRI is an appropriate and often definitive study. Our goal is to get more MRIs ordered because really that's the only way to know with an appropriate child. And there's so much disincentive right now, which is why it was one of the questions on your survey. What would maybe make you not order an MRI? Where are you getting your pressure from, or where are you not? We want to learn that.
Is there a question over there? Thank you, Luca.
Yeah, I was just going to make a comment with a little bit of reality testing, given the cost effectiveness. As a pediatric cardiologist, hearing your presentation, this is analogous to getting screening ECGs in kids who are going to be doing athletics or even a wide population-based screening program. The cost effectiveness of this, if you do the math and what's going on with the cost of healthcare. So what I would ask is, who do you recommend order the MRI, and what is the minimum criteria a primary care doctor should look for before he refers him to the specialist of Chiari and Syringomyelia types of abnormalities?
I think, that's a good question, and that's something that's evolving, obviously, and every neurosurgeon has a different opinion on that and so forth, but I think it just takes a good clinician. I think as a good pediatrician who knows their patients, and if you have predominantly a headache problem where the child's reaching or grasping for a head, pointing to their head somehow, particularly after straining activities, that's classic. And then you run into all the different ones, and I think, that becomes a little bit harder to know. And I saw, so we get MRI scans. So the classic pattern, or somebody who has headaches that are refractory, and I think we mentioned some of the other things. There's sort of these complicated patients that you can kind of in your brain figure out the brainstem may be affected. Certainly anybody who has brainstem findings, coordination problems, swallowing problems, sleep problems, like this lady, she's, snoring so loud she's a sore throat in the morning. That's not normal. And it takes a good clinician really to sort through these things, and it's a very difficult task. And I think there are no specific indications besides that strain-related headache at this point, from my perspective.
Our C board, or medical advisory board, came up with headache, choking, imbalance, arm weakness, tingling hands, dizziness, ringing ears, and neck pain. Those are the symptoms that are floating around in this cup. And what we're asking, of course, isn't for every time a kid comes in and has a headache, you order an MRI. What we're asking for is if this kid has come in a lot, it's the first year of life and you've seen this kid, 23 times already, and this is swirling around in your possibilities, consider Chiari. Maybe you're not the person who orders it. Maybe you send them up the food chain to a neurologist or something like that to see if you can get a little bit more, information before you order this expensive test. But our argument is, or our understanding is, based on research and focus groups, is that it's not being considered. it's just not being considered. Classic symptoms of Chiari are not, it's not on the differential at all. And that's what we want to change. That's really what young up-and-coming physicians can change for us. Nobody else can do that for us.
I think, this is a personal note, that the problem is not in the ordering of MRI scans. The problem is that the MRIs cost too much. And that's a problem. We should be ordering a lot more MRIs in these kids. And we would be if they cost $100. No radiation exposure, the anesthesia is safe. And I think the problem ought to be working on making screening tests that are extremely benign more available, and that's just a personal thing. I spend 25 years now preaching. I have kids come in because their pediatrician or their primary doctor, their family doctor, and HMO didn't order an MRI, and until and if you guys are, I know you guys aren't, the ones in the audience are not the ones that are the thing, but I have no constraints on ordering MRIs. I am not incented not to. And if anybody in their own practice has that, send them to me. I will order an MRI.
Right.
Please grab a coffee cup on your way out, and posters and all that.